first Lancet Commission came out in 2017, the second one was in 2020, and the third one was just a couple of months ago in 2024. And you see, I'll just read from the third one here, the potential for prevention is high, and overall, nearly half of all dementia could theoretically be prevented by eliminating 14 modifiable risk factors. So this is the 2017, 2020, and 2024 report. You can see that they're focusing here across the life course. So education, obviously, early on is very important, but these risk factors present themselves at different stages of the life course. So we need to be aware of this, and really brain health, like longevity, is recursive, isn't it? What you do today matters very much what happens in 5 and 10 years. So this is all recursive, and people need to understand that. If I could tell my 35-year-old self, I'm 40 years old now, but if I could tell my 35-year-old self what I know now, I probably would have lived the next, I'm not going to tell you how many years, quite differently. So it's a life course. Because the different risk factors operate at different time points, you have to start early and continue throughout life. I talk to my two kids about this all the time. The risk is clustered in individuals. So as you well know, oftentimes people have multimorbidity. I mean, 60% of the US population over the age of 60 have multiple chronic diseases. So the interventions need to be multi-component. It makes N-of-1 studies particularly difficult, especially with single interventions, because there's so much multimorbidity in these patients. But the interventions have to be multi-component. The good news is that the risk is modifiable regardless of ApoE4 status, because we're all concerned about ApoE4, and we know that about a quarter of the population has at least one copy, 2% have 2 copies, but this risk can be modified even, of course, if you're ApoE4 positive. We need to be really ambitious about this, both privately and publicly. The other piece of good news here is that I showed you all those risk factors. There's 14. But look at the risk factors that I think arguably all of you in this room would agree we need to focus on. There's quite a bit of evidence for most of these, but they didn't reach quite the bar for the Lancet Commission. So when I was invited last week to join the Lancet Commission, I happily did so. But you can see visceral adiposity, sleep, diet, systemic infections, mental health conditions, gut dysbiosis, and so on. Didn't make the cut. So actually, when I said earlier that 45% of cases of dementia are preventable, I actually think that number is higher if we focused on all of these other modifiable risk factors as well. The other thing I will say is that 7 of the 14 modifiable risk factors are risk factors for atherosclerotic cardiovascular disease. And we know how to treat these, and we know how to prevent these. And in fact, one of the prevailing theories now of Alzheimer's disease is not so much amyloid, although amyloid obviously is important, but amyloid may be released and secreted in increasing quantities in reaction to what you heard earlier, which is that 20% drop in cerebral perfusion and in oxygen saturation over time as our brain ages. So amyloid may be released in increasing quantities as a neuroprotective measure to try to maintain those synapses. So it's a big deal, these modifiable risk factors, especially the cardiovascular ones. And there's a massive opportunity here, because even in one of the wealthiest countries on earth, in the United States, half of our population is hypertensive, and less than a quarter have it adequately managed. Almost half are obese. Less than 2% are actually on anti-obesity treatments right now. A third of our population is dyslipidemic, and about 1 in 5 have it managed, and so on. So there's a massive opportunity here, even in highly educated, in westernized countries where medicine is at the vanguard. So a little bit more about these atherosclerotic risk factors. Boy, do we double down on these hard in the clinic. And not just double down on them, but be aggressive with them earlier in the life course and have targets. So when I was told during my annual physical 3 years ago that my LDL of 128 is really nothing to worry about because my 10-year cardiovascular risk is low, the one risk factor that was added to that Lancet Commission was LDL, responsible for 7% of cases of dementia. So when I'm, 4 years ago, when I'm told at my age that the LDL of 128 is really not that relevant because my cardiovascular disease risk is low, that's not how we need to be practicing. And so we need to be setting targets for risk factors like that, even in people who are otherwise seemingly healthy with a coronary calcium score of 0. And as I mentioned, there's an attrition of the microvasculature. We're all concerned about imaging the macrovasculature, right? Knowing what the coronary arteries look like, knowing that our carotid arteries are clear, knowing that the big blood vessels in our brain are clear. But we forget about the 500 miles of microvasculature that supplies every cubic millimeter of tissue in our brain. And it's the microvasculature, especially that penetrates the deep white matter, that drops over the life course, right, over age. And it's one of the reasons why we see these white matter hyperintense lesions, which are often passed off by radiologists, right? They don't even read in large perivascular spaces, and both of those, when I see an MRI scan, I mean, white matter hyperintense lesions are ubiquitous. Over 90% of the population over the age of 50 have them. So we think they're just aging spots and normal for aging, but they're not normal for aging. We know that those alone are independent risk factors for cognitive impairment, dementia, Alzheimer's disease, gait disorders. So we need to be taking those seriously. So when I show a patient with an LDL of 128 who have a couple of white matter hyperintensities, to me that's not acceptable. So these vascular risk factors are a risk factor not just for dementia, not just for vascular dementia, but also for Alzheimer's disease. And I don't want to geek out on you here, but one of the things that happens is that when you drop perfusion pressure to the brain and you decrease oxygen and blood flow, what happens is you overexpress amyloid and you change the way in which amyloid precursor protein is cleaved. So in a normoxic condition, you have this enzyme that cleaves the amyloid precursor protein, and so not much beta amyloid is actually produced. But in hypoxic condition, you have different secretases that cleave that amyloid precursor protein in ways that increase the amount in the expression of beta amyloid. So you can see why vascular risk factors are so critical in people over the life course. Now, it's a particularly exciting time in neurology, and it's the reason why, I traveled across the country to start a preventive brain health platform, because there's such an opportunity here for primary and secondary prevention. So we know that Alzheimer's disease, for example, the pathology begins 15 to 20 years prior to the onset of symptoms. So we've divided this now into preclinical Alzheimer's disease, prodromal, otherwise known as MCI or mild cognitive impairment, and dementia. On the right-hand side, you see that amyloid beta, abnormal PET scans, amyloid PET scans, the development of phosphorylated tau in the brain begins before any symptoms begin. So there's two major recent developments in Alzheimer's disease therapeutic research that really allows us to concentrate on this in ways we never did before. The first is the demonstration that targeting beta amyloid in the brain, because we have effective therapeutics now that can rid the brain of amyloid, is an effective therapeutic strategy. Now, we can talk all day about, and there are whole conferences around these therapies. They're not the panacea for sure, but they do slow the progression of the disease. So that's a proof of principle, if you will. The second advance is that highly accurate plasma biomarkers for Alzheimer's disease neuropathology are here. They're here. Lilly just released a p-tau217 assay that has over 95% positive predictive value when you compare it to amyloid PET or to CSF amyloid. So for Alzheimer's disease pathology, we have a blood test now that is now commercially available, which when combined with other digital and clinical phenotypic features, can very highly accurately predict who and when someone's going to develop Alzheimer's disease, as Wei Wu was suggesting today. So these two factors, one, the availability of easy-to-access blood biomarkers that are highly predictive, and new therapies, and I'll talk about repurposed therapies in a moment, increase and emphasize the need for preclinical detection. Because by the time someone has the onset of symptoms with a disease that's been brewing for 15 to 20 years, the neuronal damage and the atrophy that's occurred can't be recaptured. So the field is shifting and moving. There are now a dozen studies, including with some of the newer drugs that are looking at the preclinical treatment of Alzheimer's disease. And that's what this diagram shows you right here. The problem is that they don't present to clinical practice, so we have to find some way of screening this population, identifying those who are at higher risk, and then including them in these preclinical trials with using these biomarkers. And so there's already what's called a trial-ready cohort that's out there. It's publicly available, identifying people with preclinical and prodromal Alzheimer's disease, and there are over 50,000 people now in the United States signed up for this. And there were 2 trials. Well, I put just 2 trials here with 2 of the most recently approved anti-amyloid drugs that are now running clinical trials in patients with preclinical Alzheimer's disease. What about clinical practice? I wasn't doing this 3 years ago. We're doing it now. So what does a brain health program look like? It's really a highly proactive and personalized approach that uses the most advanced technologies to objectively and quantifiably measure current structure and performance of the brain and evaluate, assess future risk of disease. We have the capacity now in 2024 to do this. Also, you need a team of experts working together that work to optimize the structure and functional performance of the brain. When I tell people we can measure how fast you think and follow and track that with whatever interventions, not just the imaging and the biomarkers, but there's so many other markers right now that we can really, really, with high fidelity, assess the functional performance of the brain. The other thing we need to do is minimize the risk of the disease and then objectively monitor and quickly adapt to changes in performance. So if people show a decline, as Weiwu said today, I want to keep repeating Weiwu here, but I love the presentation he gave. It's so important to continuously monitor these people, right? So if someone is off course, whether their blood biomarker rises or whether you see hippocampal atrophy, you're able to jump on that or change course with whatever interventions that you've already implemented. So the evaluation of the brain should be comprehensive, precise, objective, quantitative, and the interventions are individualized and closely monitored. So we deeply phenotype and molecularly profile all of the patients in our practice. One of the things on the bottom left is the quantitative neurological examination. So the last neurological examination I had was follow my finger and tap a few reflexes. Those days are gone. Even many neurologists, the reason why we went into neurology was our fascination with localizing the lesion. I was once a program director for a residency program, and every student that wanted to go into neurology were fascinated by localizing the lesion. In the future, it's not going to be about localizing the lesion. It's going to be about anticipating the lesion and preventing that lesion from developing. That's the future of neurology. So we have the capacity now in a very objective and quantitative way to assess saccadic eye movements, vision, hearing, speech, olfaction, gait, motion, stability, sleep, all of those. And when we see any decrement in any of those, we know that we need to be concerned about that patient. So I'm not going to go through the details here, but just take my word for it, we're deeply phenotyping these patients. And we're collecting data, because all data has intrinsic value. That's not necessarily actionable. So on the top right, you'll see we do arterial spin labeling, looking at cerebral perfusion, and every time we run an MRI scan. And we do diffusion tractography, so diffusion tensor imaging, looking at the architecture of the brain, the structural integrity of the white matter tracts. Now, do we use that now? No. But all of this is being housed in a data registry that we will bind. So what we're doing here is really a prospective longitudinal cohort where we have deep, deep data on these patients in a longitudinal fashion over time. And we'll begin to understand and maybe take advantage of some of the data we're collecting, including the biobank that we have as well. Weiwu again said today that we can actually put an age on a patient's brain. So we do volumetrics as well. We measure the volume, the size, the mass, the surface area of 25 different structures in the brain. So we can tell what someone's hippocampal size is. We can also tell what the surface area and thickness of their gray matter is. One of the things I also like about this AI-generated platform is the ability to now quantify white matter hyperintensities and enlarged perivascular spaces. As a stroke neurologist, I've had a longstanding interest in this area. And as I mentioned before, this is a risk factor. So when we see these, I no longer pass these off. In fact, I have to go back to radiologists. As my nurse practitioner here, Karen, will tell you, I sometimes will have to go back to the radiologist to tell them to reread because they missed all the enlarged perivascular spaces. They don't even report on it. So now we have the ability to actually quantify these and follow these and to see how our interventions are actually changing these parameters. It's a team sport. Just like this longevity conference here, I've been so impressed with the warmth and how I've been embraced. You know, you're never too old, right, to recreate and reinvent yourself. Although, well, I won't go into it, but so I'm kind of reinventing myself now by getting more into longevity science, but I'm so impressed with this community. They're so welcoming, they're so collaborative, and when you're building a field, like we're trying to build the brain health field, when you're building a longevity field, like Eva and CP and Andrea and others are, I'm so impressed and so grateful for how they've welcomed me into this community. But it takes a team. And so our team, because I've limited knowledge, and when medical knowledge is doubling every 2.5 months, there's no way for one of us to possibly keep up with this. So surrounding the brain health team is a metabolic, heart health, internal medicine, nutrition, and you can see. So it takes a team. And then around that team, we built another team, an Academy of Science and Medicine, that houses leading thinkers and key opinion leaders, including Eva and Andrea and others, who can give us current best thinking on whatever clinical issue arises and can keep our clinical protocols at the tip of the spear because medicine is advancing very rapidly. So it really takes a team, and the only way to biologically optimize the human health of an individual, we just collected 45 physicians from academic medicine, cardiologists, neurologists, women's health experts, you name it, none of whom really practice preventive medicine before, maybe except the cardiologists. But then bringing them together and finding a way to integrate that group so that they work together, because it's one thing to create all of this data. It's another thing to be able to analyze, interpret, synthesize this data, and then make recommendations, align on the recommendations that you're going to make. So that's why it takes a team. It's not just enough to produce data and a booklet of information. You need a team to be able to interpret all of that and action it. So the interventions, as I discussed very early on, need to be multimodal, highly personalized, and yes, evidence-based, but I'll also say evidence-informed and risk-adjusted. What do I mean by that? I'll show you what I mean by that in just a second. But, you know, we heard a lot about GLP-1 agonists and other potentially effective therapeutics to optimize brain health and prevent dementia. So looking at the risk of a certain intervention, taking advantage of the emerging evidence, getting consent of the patient, intervening with that intervention, because people are going to longevity clinics. They want answers that they're not getting from traditional medicine. So if we give them an intervention that's not evidence-based, but is evidence-informed and risk-adjusted, and we monitor them closely for any adverse effects that occur, that's where you get these N-of-1 studies, and that's where you start to create data that really advances the field. So yes, a lot of things happening, but I'm at a longevity conference, so I just mentioned a gerotherapeutic, which has been mentioned a number of times here before. But before I do that, this is from, you've seen Nir Barzilai present this, so this is his Geroscience-guided repurposing of FDA-approved drugs to target aging. But I would also say to target dementia. So the ones I've highlighted in red are those that are in randomized placebo-controlled trials now in people with preclinical Alzheimer's disease or MCI, prodromal Alzheimer's disease, to prevent the onset of dementia. And I've listed those ongoing trials below. So there's a lot of activity in this area, and it's really exciting. And why is there so much excitement over the GLP-1s? We've heard a lot about this at this meeting. Think about a drug that reduces many of the cardiovascular and metabolic risk factors that are causes for dementia, that increase the risk for dementia, but also one that's directly neuroprotective. GLP-1 is a neurotransmitter in the brain. I don't know how many of you knew that. What is it doing there? Actually, it reduces the expression of beta amyloid and tau. It increases the clearance of beta amyloid and tau. It reduces neuroinflammation. It improves insulin sensitivity, not just in the body, but in the brain. It reduces oxidative stress. It increases neurogenesis in the hippocampal formation. So it creates new neurons in the hippocampus and actually improves synaptic plasticity. So not only do you have a drug that reduces the risk factors that increase the risk of dementia, but you have a drug that is directly neuroprotective. So that is why I think there's a lot of excitement around these medicines. So if somebody comes in and says, I've heard about GLP-1 agonists, I'm not really overweight, I don't have diabetes, maybe I have a little hypertension, but I'm really interested in starting that drug because I have these risk factors for dementia. Do you put them on it? Is there evidence based there? No. But can you make an evidence-informed and risk-adjusted decision to put that patient on that drug? Sure you can, as long as you're going to follow, monitor, and track that person. As Jim Kirkland said, sometimes these people will go on these drugs anyway, so let's learn something from them. This is just a number of pieces of data that has created the excitement around the GLP-1 agonists. So there's a Swedish national register, there's a Danish national register, all of which appear to point in the direction that these drugs, when used in diabetics, at least, even when compared to other anti-diabetic drugs, reduce the risk of Alzheimer's disease and dementia by up to 30%. And there was a phase 2 study, this was presented yesterday with liraglutide, which showed an 18% slower decline in cognitive function in people with Alzheimer's disease. Now, it's a bit late. Even when you can show that degree of reduction in someone with end-stage disease, that's important. But can you imagine if you got to someone with MCI or even earlier in the preclinical stage? And that's where all the excitement is right now. Nir, I don't know if Nir is here. I put this in for him because metformin, obviously, is also directly neuroprotective in some of the same ways that GLP-1s are. So just like GLP-1s, it reduces cardiovascular risk and reduces those CV risk factors that increase the risk of dementia, but also is directly protective. And now there are a number of different systematic reviews, meta-analyses showing that metformin may reduce the incidence of dementia and Alzheimer's disease as well. However, this is where the personalization comes in. This is from the National Alzheimer's Disease Coordinating Center in the United States. And they showed that not only was metformin protective, but it was associated with better immediate and delayed memory in cognitively normal people with type 2 diabetes, but only in ApoE4 non-carriers. In fact, there was a greater decline in memory with ApoE4 who were carriers. There's where the precision needs to come in. You just can't start these medicines willy-nilly. You have to understand the patient that's taking them, and that's where the personalization and precision comes in. It goes beyond preservation, though. It's about optimization. So I believe we can cognitively enhance, and you've heard that throughout this meeting, people's cognitive performance. And so, cognitive adaptive training is something that has a long history of evidence. It's level 1 evidence. There's grade A evidence here that cognitive adaptive training, and I've just listed some studies here, but look on the top right, cognitive exercise using different platforms actually improves cognition in most people. And you can see here the speed of information processing, the average improvement was 41%. The average improvement for working memory and narrative memory was up to 20%. So if I told you by spending 20 minutes a day in a cognitive adaptive training program, 3 to 5 days a week, could increase your processing speed by 40% and your working memory by 20%, would you do it? Probably. So I think the fact that we also take advantage of this as well, and this is the poster child for cognitive adaptive training, right? Physical training wasn't enough for him, and even though for those of you not from the United States, I'm sure you'll recognize Tom Brady. But he attributes his ability to read defenses and to quickly process information and get the ball out of his hands quicker than anybody else in NFL history to cognitive adaptive training. And it was that he believes changed the trajectory and course of his career. So in conclusion, brain span, I think we need to be talking about brain span when we talk about health span. Brain health and longevity are deeply interconnected. We're at an inflection point. Brain health, as I showed you, has recently become a global public health priority and is giving rise to a new field of preventive neurology. One of the preventive neurologists I work with, who started a preventive neurology clinic back in 2012, I think, was seen as not just a maverick, but maybe just crazy back then, 10, 12 years ago. And now it's a field for which papers are finally being written about. This is the future of neurology. It's not about localizing the lesion, remember, it's about anticipating and preventing the lesion. Brain health and longevity are inextricably linked, and the prevention and management of overlapping risk factors will reduce chronic diseases of aging, extend healthy lifespan, preserve cognitive health, and reduce neurodegenerative disease and stroke. The preclinical detection of neurodegenerative disease is a reality. It's here. Now, you can't get these biomarkers if you're less than 55 and unless you have mild cognitive impairment now. Insurance won't pay for it, right? But they're here. And in the not too distant future, when you go in for your annual physical, or hopefully your quarterly physical, right, Wei Wu? Yeah. Although you won't have to go into the doctor every quarter. Nobody wants to do that. But when you are monitored like that, you'll not just go in for a blood draw that gets a CBC and a lipid panel, but you'll have, as one of my colleagues like to say, a cholesterol test for the brain, right? You'll have a biomarker. Because right now, even in neurology practice, when someone comes in with a non-cognitive problem, I challenge you to show me how many of those people have actually had a mental status exam. And so CP, the average MoCA score of 25 doesn't surprise me at all, despite the fact that the average age was 57 or around 60 years of age. Doesn't surprise me at all. Because what do you see, even amongst neurologists who are examining people for epilepsy or migraine? A&O times 3, alert and oriented times 3. That's the status of the cognitive exam. So that has to change. We can be much more objective and quantitative now. But it takes a team, and so right now we're in the process of, we built out the team. We do practice evidence-based, but we also practice evidence-informed and risk-adjusted medicine. We also practice evidence-generating medicine. So we're collecting a lot of data in a prospective longitudinal cohort that we think will inform the field as we move forward with that real-world evidence. And ultimately, we're there to validate a model of care that I believe can be scaled.